Hello, everybody. Hope you're doing well. Nate Lighthizer here, faculty member at the Oklahoma College of Optometry. Excited to talk to you about ERG and how this plays a role in our ischemic status of the retina. What should we monitor these retina patients, or should we refer these retina patients? ERG has evolved tremendously over the course of the last 10 to 15 years, and now it is handheld and we can move it from room to room. Very quick, very efficient, patient friendly, doctor friendly, staff friendly. We know probably diabetes and diabetic retinopathy is our number one protocol. Glaucoma is going to be up there as well, but don't forget about your other retinal conditions: vein occlusions, artery occlusions, hypertensive retinopathy, ocular ischemic syndrome. If you have any changes going on in the retina that you detect with your dilated fundus exam or with your wide field fundus photos, grab that ERG. Is there any evidence of ischemia going on? What is the ischemic status of that retina? Again, that's going to give you powerful info to refer or to hold on to this. So again, I told you about myself. ERG, RedEval, objective functional data gives you confidence. Knowledge is power, gives you confidence there. So let's talk about this 50-year-old female. This patient was in for punctal plugs, so not even in for a retinal evaluation, but the student and resident I was working with noticed that vision was down in the left eye in this long-standing diabetic, hypertensive last blood pressure reading. You can see it was there. They smartly did an OCT that showed this OCT in the left eye. Remember, vision was 20/40 in the left eye and 20/20 in the right eye. Certainly looks like central serous chorioretinopathy in this left eye. That's what it looks like. What's the diagnosis? Again, looks like central serous chorioretinopathy, and our typical management for that is going to be observe, monitor, watch that back. We took photos of the left eye. Obviously, you can see the OCT and the fundus photos of the left eye showing central serous. We said, well, let's take photos of the right eye as well. There's the photos in the right eye. And a representative, there's another photo, more macula there, and a representative example of the OCT, not in this patient, but just showing you what the macula looked like, flat and intact. You can see why this patient is 20/20, but do you notice any changes on the back of the right eye? This was not the eye we were concerned about at this point. Again, this was the 20/20 right eye. It was the left eye that was the 20/40 central serous eye. Typical management for central serous. I'll see you back in a month for a vision check and an OCT. We'll follow this, we'll monitor, we'll observe, and the vast majority of these cases will resolve on their own. 1 month later, OCT is moving in the right direction. The central serous in the left eye is moving in the right direction. Nice photo. You can see that pocket of fluid in the left eye, central serous. We took a photo of the left eye. Let's take a photo of the right eye as well. And note, again, this is the 20/20 eye. This is not the central serous eye, but we were taking a photo of the left. Might as well take a photo of the right eye. And you look here and you go, huh, that looks a little different than it looked a month ago. There was the photo a month ago and those hemorrhages weren't there. And clearly we've now not got some hemorrhages associated with some venous engorgement. Look at the nasal side of that disc. Interesting findings here. And shame on me. I kind of went, that's not the eye we're worrying about. We'll see you back in a month for a vision check and an OCT. So now we originally saw in September, then October. We'll see you back in November. 2 months later in November. Central serous in September, October, November. Central serous is doing what central serous often does. It's moving in the right direction. This is good. I like to see that. Yep, that pocket of fluid in the left eye is improved. Visual acuity is improved. We're moving in the right direction in the left eye. We take a picture of the right eye, and you take a look at this, and you go, huh, the hemorrhaging appears to be getting worse. And you go around to the different quadrants, and you're seeing scattered hemorrhages in all different quadrants. I think the red free really shows it well. Is it time to stop ignoring the right eye? What do you think? Absolutely it is. So, and again, the OCT still looked good. We know we've got central serous in the left eye. What's going on in the right eye? Is it an artery occlusion, a vein occlusion, ocular ischemic syndrome, or diabetic retinopathy? Remember, this 50-year-old female has longstanding diabetes, hypertension. My top two differentials were ocular ischemic syndrome and a retinal vein occlusion. Number one was was a retinal vein occlusion because of those dilated, tortuous retinal veins, scattered hemorrhages across all four quadrants, both peripherally, mid-peripherally, but as well centrally. Vein occlusion was my number one. We did rule out ocular ischemic syndrome. I sent her to her PCP. Certainly going to consult with the PCP. The question really is here is are you going to refer this? Are you going to observe this? If you send this to retina, what are they going to do? They're going to watch it. They are going to watch this for the development of two things. Do they develop macular edema? And do they develop ischemia neovascularization? This is a vein occlusion. The carotid Doppler that we sent for came back normal, unremarkable. It was all good. So we ruled out ocular ischemic syndrome. It confirmed our thinking of a vein occlusion. And you can have ischemic vein occlusions and you can have non-ischemic vein occlusions. Your severe vein occlusions and your more mild vein occlusions. Yes, I would fault nobody for sending this to retina. An FA or an ERG is needed. The ERG is certainly much more non-invasive. Is this ischemic or is this non-ischemic? We did our Flickr 16 protocol, and you take a look in this particular patient and notice a very, very normal ERG, normal ERG in terms of the amplitude, in terms of the implicit time, the waveforms look good. This is normal retinal functioning, and this is evidence. This is guidance. This is power for you to say, you can hold on to this patient if you so desire. There is no ischemia going on at this point. OCT confirmed no macular edema, and we can monitor this closely. We can monitor this very, very closely. If it had looked like this, if it had been like that, where we've got a low and slow ERG, look how these waveforms, they're supposed to be in the boxes. These are low and slow amplitudes and latencies are reduced. Again, all in the red, that would be abnormal. Again, this patient's ERG looks good. Peaks where they should be, all in the green. Waveforms look good, both implicit time and amplitude. It's a normal ERG. The retina is functioning normal, minimal to no ischemia. So I held on to this patient. They no-showed a month later, 2 months later, and there you go. Looks good. I was nervous on this visit, but the ERG was correct. This was a mild non-ischemic vein occlusion. It resolved on its own. We've got some collateral and shunt vessels on the nasal side of the disc, but the ERG was correct. Its knowledge gave us power to hold on to this. The ironic thing was central serous came back in the left eye in this particular case. So the ERG was right. There was no ischemia. This case likely wasn't going to go bad. You can follow this closely. Keep the patient in your practice. Patient's likely going to prefer that. Non-invasive retinal function, retinal ischemia. It helps to tell us, is there any of that going on? In this case, there was no ischemia going on. We could not have determined that without an ERG or a fluorescein. So we save the patient a visit and injection, and we follow that patient closely. So that the ERG, big time value with the ERG. It's like the EKG. Cardiologists wouldn't want to get a complete cardiac picture without an EKG. You want a complete retinal picture without an ERG. It's fast, it's quick, it's non-invasive. You can do this dilated or undilated for the vast majority of tests. We want structure and function for our patients. So appreciate your attention. Hope that case helped you in your retinal conditions. Remember those protocols like the Flickr 16 with the ReadyVal. Nate Lighthizer, have a great day.